Our next speaker is Dr. Michele Petri, who's professor at Johns Hopkins. She received her MD at Harvard, intern resident M.G.H, fellow at UCSF, and got an M.P.H at Hopkins. And she's going to give us a lupus update.
I had to limit myself to 10 things in this update. I wanted about 50, but I picked the ones that I thought would be most relevant immediately in your clinical practice. So let's start out with the new SLIC classification criteria. I want classification criteria to be used in the clinic. They should not be relegated to enrolling patients in clinical trials. So the SLIC classification criteria have two overarching principles. And the first is that lupus is a disease driven by autoantibodies. So in order to be classified as having lupus, the patient must have at least one clinical manifestation and at least one immunologic one, adding up to a total of 4. So we kept that ACR total of 4 to make it easy. The second overarching principle is if the patient has lupus nephritis, that's all they need. You don't have to keep counting. That patient has lupus. Now, here are the clinical criteria, and the most important thing is that the definitions are so much more inclusive than the ACR was. So for the first one, acute cutaneous lupus, that now also includes subacute cutaneous lupus. For chronic cutaneous lupus, it's not limited to just discoid. It includes tumid lupus, verrucous lupus, lichen planus-like lupus. And for the oral and nasal ulcers, that is, of course, the same. But non-scarring alopecia, that's an objective manifestation. It doesn't mean that patient complaint of hair fall. It means on your examination, you see the broken or missing hairs around the frame of the face. Because in lupus, remember, there are 2 hair findings. The first is that the hair is thinner than normal, and the second that it is much more fragile than normal. Now, the other organ systems are represented the same way they were in the ACR criteria, including synovitis, serositis, renal. Renal is for those patients who did not have the kidney biopsy. But look at the changes in neurologic. It's not just limited to seizures or psychosis anymore, because there's so many other manifestations that are specific to lupus versus other connective tissue diseases. Another big change is that the hematologic criterion has now been split into the 3 different cell lines. Now here are the other half. Here are the immunologic criteria. Remember, you have to have at least one from this list. Now, we're stuck with the ANA. It's still there. But for anti-DNA, we've all had such problems with the new ELISA assays. The patient referred because they're 1 or 2 points above the so-called normal range. So we've tried to fix that. To use it as a classification criterion, you have to be twice above the upper limit of the ELISA assay. In the old ACR criteria, all the immunologic ones were lumped into one. And obviously our new SLIC criteria are trying to emphasize that this is an autoantibody-driven disease. So you'll see that anti-Smith is split off. It's a standalone. And the anti-phospholipid antibodies are a standalone. And by the way, the anti-phospholipid antibodies include anti-beta 2, but in particular include the IgA isotype. Because when we did this exercise, it turned out that SLE patients love to make IgA anti-beta 2, and this is very specific when we compare lupus patients to other connective tissue diseases. Now, I know you're thankful that low complement is there, because it never made sense. Why was it left out of the ACR criteria? But the last one may surprise you. Why is the direct Coombs there? Well, don't double